the HIT has been going now for 18 months, and I don't know hardly anybody in this audience or why you've come here. You might have come to hear about sexual health, or you might have come here to hear about addictions or whatever. So I don't know really what you are looking for here. So I hope that you'll ask as many questions as possible and get what you want out of this session, because I could talk for hours about the stitch, about things that you might not be interested in. So. Okay, so David Gunnell there is one of the key collaborators on this HIT. We've got a number of different people involved in our HIT. Most crucially, we've got the SISH group, which is a self-injury, self-harm network in Bristol, which is a cornerstone of our patient involvement. And when we first started the HIT, I thought we didn't have a hope in hell of getting any patients involved, patients who perhaps attempted suicide. I couldn't see for the life of me how they were going to want to talk about that experience later on, but actually we had an enormous and huge response, and continue to get a lot of patient and public involvement in the HIT. There's a wide range of people involved, and we've got 78 work streams, which is rather too much. The first thing and the most important thing that we did was establish the self-harm register, and this gives us 40 pieces of information about every single person who self-harms, and that is from superficial lacerations right the way through to attempted hanging. Anyone who harms himself and attends a Bristol hospital, so that's the BRI, Southmead, or the Children's Hospital. So we are gathering we are gathering more and more information as the years go on about what kind of people self-harm in Bristol, and what areas they come from, what gender, what ethnicity. We're gathering lots and lots of information, not just about them, but about their risk and about the outcomes, what happens to them after they leave the hospital. So we're getting loads of information, and that forms the basis of a lot of our research, of a lot of our changes that will take place. We benchmark it against the self-harm register to see if things have changed. I spoke a bit about the PPI, and we haven't got much time to talk about it, but please ask me if you want to. The two key areas we concentrated on in the first year were people going to intensive care following overdose of prescription medication, and emergency departments, because there's lots and lots of research that says that anyone with a mental health issue going to emergency departments get a pretty poor deal. And so we spent a lot of time talking to staff, talking to patients, questioning, using questionnaires, and getting a feel of what it was that was going wrong for people when they came to ED, and trying to address that. We've put together a business case which has had a massive impact on changing service, and so from Monday to Friday 9 to 5, there's now a 7-day 14-hour service to the emergency departments, the emergency department in the BRI, and that's being developed for Southmead as well. We've got 3 research publications, and we've recruited over 100 patients to research projects. As I mentioned, the self-harm register provides the benchmark for all the work that the Stitch does, and I think nothing could have been better than our close collaboration with the University of Bristol, because that's opened up huge possibilities for us in understanding evidence-based practice. So for example, the self-harm register can tell us, and this is the most simple one, how many patients came in. Previous to the Stitch and the self-harm register, previous to that, nobody knew how many people in Bristol were self-harming and attending emergency departments. All national and local statistics talk about hospital admission, but they didn't talk about emergency attendance, and so nobody knew who these people were and what they were doing and so on. So as you can see with the smaller line underneath, we started collecting in Frenchay the middle of last year before it closed, and now that's gone to Southmead, and so over the years we'll collect lots and lots of data about those. And how that connects in to the HIT. I'll just go back a bit there. So for the Stitch, We wanted to know how many people were coming into hospital, and we've got those figures. How many people were taking dangerous medication in overdose, this is tricyclic antidepressants for example. How many people when they came to the hospital were actually getting some psychological intervention of some sort of assessment, some sort of help to move on. How many people were going into hospital for a medical admission, how many people went into ITU, and how many length of stay, how long people stayed into hospital. And these are key indicators so that we can look at these things and we can put some intervention in, for example, GP training, and I'll talk a little bit about that if I've got enough time, and see whether that impacts on any one of these key indicators. Okay, so the challenge was lots of people in Bristol who were on antidepressants or on some sort of medication were taking that medication in overdose, and some of those people were ending up in intensive care, or even worse, ending their lives. And so we wanted to have a look at that and how we could make a difference. And so we found out who they were. We've started a GP pilot at the Student Health Centre and looking at people just having 3 days prescriptions or 5-day prescriptions and seeing how that works for people. I went out to meet with all the GP forums, and we've put a lot of pressure on the government, and it's been raised in Parliament, and we're going through NHS England to try and get a change in the law to allow GPs to just give out medication in small amounts, but at the same time not costing the patient any extra, because at the moment it's not helpful at all for the patient because they've got to pay every single time. So those are the challenges, and I think the success has been we've managed to do education and training. Yes, well I put that one up because that's supposed to be in essence the GP. We've done education and training to 240 GPs in total across Bristol around this very issue, around overdose of prescription medication, around suicide, about recognising self-harm, about what to do if someone comes to your surgery following self-harm, and so on. Now, the interesting and very useful thing about this is it's had absolutely no impact whatsoever on the prescription behaviour of GPs. I think it's been a fantastic thing to do. It's now embedded in the GP training in Bristol, so every year we're being asked to do this training. But actually, looking back at the self-harm register, it has had no impact whatsoever, and that's the key thing about the relationship with research and with actual practice. Does it work? Has it had an impact? And so quite obviously we're back to the drawing board. We're going to now have a look at what can we actually do to impact that behaviour. Okay, so we've got some research plans. As I say, there's been a large investment in self-harm services in the hospital, so we've now got the 7-day service, and so we're going to be evaluating that. Is it useful again? Benchmarking against the number of people that come in and all the other outcomes that we've got. We've got a Clark-funded project to look at what do the patients think is a good outcome. We know that for hospitals and perhaps for CCGs, a good outcome is less length of stay or reduced admission to hospital. But what does the patient feel is a good outcome for them? Do they want to stop self-harming? Is that a good outcome, or are they asking about other things? So we're doing a big research project on patient-centred outcomes for self-harm. We're maximising patient involvement with self-harm research in a lot of different ways, and again I can talk about that if people are interested. And then we're looking at RCTs of interventions, what sort of interventions to improve self-harm outcomes. Okay, our future plans, again, I have to keep reining myself in because there's such a huge thing, loads of things that we could be doing, and I'm really excited about it. We're going to be teaching 60 ambulance crew next Wednesday around self-harm, recognising self-harm, what's the difference between self-harm and suicide, how do we recognise risk and things like that. We're piloting a self-harm clinic which is attached to the emergency department, so that people who come in following self-harm and maybe have come in a couple of times, we'll ask them if they'd be interested in having some CBT therapy for that, and up to having some sessions in the hospital, and see if that impacts on self-harm behaviour. We're extending out to carers information for self-harm and suicide attempts, because that's really, there's very little around. And what is it about patients that leave the emergency department without being seen, and we want to have a look at those in more depth. David mentioned in his talk around how we can make mental health partners more effective in joining up all these diverse groups of people to fund projects that will help Bristol as a whole. The self-harm register is on very rocky ground. We get money from bits and pieces of money from different people in order to fund it. So the business case is going to the Bristol Health Partners to see if it can be funded from the partners themselves, and this is going to be a sort of breakthrough case to see if other HITs can do the same. The key things for us over the next couple of years are, let's get into this GP thing, let's find out about why this is happening and what we can do to change it, and evaluating that 7-day service, because that's the CCG have taken us seriously. We need to prove that we're having some impact and changing lives for the better, and so that's it.
Thank you very much.